Stop trying to memorize every drip in the ICU at one time. Let's learn one at a time. That's the easiest way to do it. My name is Leah. I've been an ICU nurse for 19 years, and we're starting our series, Drips in the ICU. And today we're going to talk about norepinephrine, also known as Levophed. So anytime you're thinking about a drip, one of the first things that you should be thinking is, why is this patient on this drip, and how does this drip work? So when we have norepinephrine, what it does is work on the alpha receptors by causing vasoconstriction. So alpha receptors are going to cause vasoconstriction, and that's how we're going to increase the blood pressure. And also we're going to see some beta effects as well. That's going to cause increased contractility as well as a few other cardiac things that are sometimes negative that we'll talk about later. A patient would be on norepinephrine most likely because they had hypotension. We should be asking ourselves, why is this patient's blood pressure low or getting lower? Is it because that they're in septic shock? Is it because they're in cardiogenic shock? There's some different things we can use to understand the why, but we should know we're on it for hypotension, but why is the patient hypotensive? So we can be correcting that, not just starting Levophed. The next thing that we want to think about is, what are we going to be titrating this for? So we already said the patient's hypotensive. So most of the time you're titrating for a MAP goal. The most common MAP goal that we use on norepinephrine is to keep the MAP greater than 65. That will make sure that we're perfusing all the organs, the brain, everything. But you need to look at your order. When the provider puts the order set in, it's going to say titrate for. Every once in a while you'll see for systolic blood pressure, but most of the time you're going to see for MAP, and then it'll be a number usually greater than 65. What dose might I see? This will depend on where you work. So some facilities use mics per minute and some use weight-based mics per kilograms per minute. If you use mic per kilograms per minute, a lot of times you initiate this drip at 0.05 to 0.1 mics per kilo per minute, but you need to look at your order set and you need to make sure that you're following the order that has been put in the computer. So how to assess this medication after changing it? So since we started this for having a MAP greater than 65, as I'm increasing my norepinephrine, I am looking at that MAP. Hopefully I have an art line if I have a patient crashing, but at least I have a cuff and I'm watching that MAP to see, is it getting better? Is it improving? Is it going the way that I need it to go? I'm also going to be checking to make sure the patient's mentation isn't worsening. I'm going to be making sure that the urine output is not worsening. Skin cap refill, color, all those things still look how I expect them to look. If I am increasing that norepinephrine pretty quickly, I need to let my provider know way before I get to the max dose of that medication. So what are some medication-specific complications that you really need to be watching out for? Well, there's a ton of them, but the top three that I would say are tachycardias. You may have to talk to the provider and see if there's a different medication they could add so you can pull back a little bit on the norepi so that you don't have to experience so much tachycardia, which is going to affect so many other things, including your cardiac output. Another thing that you would want to watch out for is for ectopy. Sometimes norepinephrine could be associated with different ectopies. And finally, you really want to watch out for extravasation. All right, let's check off Levophed from our list. And next up, we're going to be going through vasopressin.